So welcome to yet another Wednesday evening where we explore the mysteries of the role of reproductive immunology and immune modulation in RPL and RIF. This is the why, when and how series, and this Wednesday we are going to explore the how immune modulation in RPL and RIF. So let me first introduce Dr. Mohan Raut, who is a consultant gynecologist and obstetrician. He's a partner, Dr. Raut Center for Reproductive Immunology and Women's Hospital. And he's been involved in active immune therapy. He started the India's first immune therapy center recognized by DCGI with Dr. Mrs. Mugdha Raut, and currently writing a book, Immunology in Repeated Miscarriages and Implantation Failure, New Horizons, with Dr. Mugdha Raut. So may I request Dr. Mohan to please take the proceedings ahead, and thank you very much for making for this program. Thank you.
Thank you, Mr. Session, for the introduction. Good evening, friends. Welcome to the third webinar in the TOG webinar series on role of immunomodulation in repeated pregnancy loss and recurrent implantation failures. In our first two webinars, we saw that in the first one, we saw that why immunomodulation should be done or should be considered in these patients with RIF or RPL. In the second webinar, we looked at when immunomodulation is done, in which cases it will be beneficial, and whether we can select couples who will be benefited by immunomodulation. And today, in the third webinar, we are going to see how immunomodulation is done, what are the various modalities of immunomodulation, their merits, demerits, and limitations. Friends, reproductive immunology is an important field in immunology, and it deals with the immunology of normal pregnancy, its role in maintaining healthy pregnancy, and in certain obstetric complications like recurrent implantation failure, repeated pregnancy loss, intrauterine growth retardation, the pregnancy-induced hypertension. All of these have immunological basis to it. You will agree with me that in our practice, we come across these type of patients who have the miscarriages or IVF failures, but we don't find any underlying cause, and maybe it forms a big chunk of the total patients. We are helpless in these cases, and we label them as unexplained, and sometimes leave them to nature. The basic aim of this series of webinars is to focus to find a solution to this problem, and whether alloimmunity or alloimmune rejection is the underlying cause for these unfortunate problems. So after the first two successful webinars, today is the third webinar. But before I start, I would like to remind all viewers, all of you, that our fourth webinar next Wednesday, 19th August, is going to be the most important webinar, where we are going to discuss the recent evidence, controversies, and future of immunomodulation in RIF and RPL. So don't miss that. So let's start today's webinar on how immunomodulation, and I will invite Dr. Mugdha Raut to give her valuable thoughts. Dr. Mugdha Raut, she is the partner of Dr. Raut's Center for Reproductive Immunology. She is the editor in Evidence-Based Women's Health Journal of Evidence-Based Women's Health Society Egypt, managing director of Dr. Raut's Women's Hospital. She is on the Education Committee of American Society of Reproductive Immunology, member of the Journal of Editorial Board of Journal of Evidence-Based Women's Health Society Egypt, member of American and European Society of Reproductive Immunology. There are various awards to her credit. The Times of India Healthcare Achievers Award in 2018 for innovative work in reproductive immunology, Primetime Healthcare Achiever Award, Femina and Cosmopolitan Top 10 Influential Women, and iGlobal Healthcare Achievers Award. She has currently writing a book on immunotherapy, repeated miscarriages, and recurrent implantation failure, A New Horizon, with Springer publication. And there are numerous publications are to her credit in various in American and European societies of reproductive immunology journals. So over to Dr. Mugdha Raut for her talk.
Dr. Mukta, you are muted currently. May I request you to unmute, please?
Good evening, everyone. Uh, at the beginning, I would like to thank Bharat Serum and Science Integra for giving us this option of this opportunity of talking about a topic of reproductive immunology, something which is very close to our heart. In the last two series, we have seen why immunomodulation and when immunomodulation. So today's talk is going to be on how immunomodulation. There may be a few slides which we may recap of the last two seminars, but just a few slides. So how is immunomodulation done in RPL and RIF? Immunomodulation incorporates all the therapeutic interventions aimed at modifying an immune response. This immunomodulation may be limited to a specific single antigen, or it may be a non-specific immunomodulation which alters a host's reactivity to many different antigens. Any immunomodulator is defined as a substance, biological or synthetic, which can suppress, stimulate, or modulate any of the components of the immune system, including the adaptive and the innate arms of the immune system. The concept of immunomodulation emerged in 1796 when Edward Jenner, who is known as the father of immunology, undertook the first vaccination. Since then, many attempts have been made to help the immune system to face the bacteria, viruses, or from internal attacks of cancer and autoimmunity. A brief recap, we'll know that the function of the immune system has two activities which are interrelated. Whenever an antigen is presented to the immune system, it first recognizes the immune system, discriminates it between self and non-self, and the response is going to be where it destroys the antigen. Either it destroys the antigen like infectious invaders or dysregulated cell, that is cancers, or it tolerates the self or the alloantigens and pregnancy. This immunological equilibrium of balancing the lymphocyte activation and control is extremely important for maintaining our bodily function. So who are involved in the immune system? In the innate immune system, we have the complement, we have the granulocytes, monocytes and macrophages, NK cells, mast cells, and basophils. The adaptive immune system involves the B and the T lymphocytes, the B antibodies, the T helper, cytotoxic, and suppressor cells. So where is the therapeutic application of immunomodulation? It is used in autoimmune disorders and in organ or tissue transplants like kidney and bone marrow transplant and pregnancy. Because in the first webinar, you may remember, I had mentioned that the fetus is a semi-allograft. The embryo and the gestational tissues express foreign antigens, which are derived from different maternal and paternal chromosomes. As the fetus gets 50% of the MHC genes from a genetically non-identical father, the fetus is termed as a semi-allograft. And surprisingly, in 90% of the cases, this semi-allograft is accepted by the body without causing any problem. This is known as the paradox of pregnancy. Now, the actual thought of reproductive immunology goes to Sir Peter Medawar, who began with this question: how does a pregnant mother manage to nourish within herself for many weeks and months a fetus that is an antigenically foreign body? And that is where the research for reproductive immunology began. We all know that in a normal pregnancy, the maternal lymphocytes are not ignorant of the embryo, but instead they are actively primed to recognize the conception antigens as indicated by the presence of activated T cells and antibodies in the blood of pregnant women, leading to immunologic tolerance. So what is an objective of an immunomodulation in pregnancy? Whenever there are pregnancy complications or repeated pregnancy loss or recurrent implantation failure, we can say that immunomodulation is a prevention better than a cure. It helps to induce effective and protective immune response for the pregnancy. It helps to maintain the immune surveillance, and it overcomes immunosuppressive effect of stress and environmental pollution. So what are the characteristics of an ideal immunomodulator? An ideal immunomodulator should have a short withdrawal period. It should stimulate both specific and non-specific immune response. It should be active through the oral route, compatible with other drugs. It should have a defined chemical composition and a biological activity, and it should be inexpensive. On the other hand, it should not be toxic, it should not be antigenic, it should not be pyrogenic. There should be no long-term side effects on the body, and it should not cross the placenta. So what are the immunomodulators based on their action? Either they can be immunostimulants or immunosuppressants. Immunostimulants enhance the basal level of the immune response, whereas the immunosuppressants suppress the immune system. And a balance of use of both is extremely important. Immunomodulators can be physiological products, which include neuroendocrine hormones, cytokines, glucocorticoids, cellular products like the lymphocytes, chemical compounds like zinc, ascorbic acid, vitamin D3, and hydroxychloroquine, and herbal products like ginger, aloe vera, tulsi, Chinese herbal products, ginseng, etc. So the immunomodulators of pregnancy may be chemicals, may be recombinant cytokines like interferons, interleukins, or colony stimulating factors, and immunization, which could be through LIT, that is lymphocyte immunization, and immunoglobulins. So what are the modalities of immunomodulation in pregnancy? The modalities are LIT, that is lymphocyte immunization therapy, which is an active form of immunomodulation, IVIGs, steroids, prednisolone, progesterone, anti-TNF alpha medications, intralipids, low molecular weight heparin, low dose aspirin, GCSF, growth hormones, L-arginine, endometrial scratch, endometrial flushing with HCG, endometrial building flush with GCSF, and a combination of all of the above. So let us see the first one. Active immunization is stimulation with an antigen, and a passive immunization is done with a preformed antibodies like IVIG or anti-TNF alpha agents. So what is lymphocyte immunization therapy? Lymphocyte immunization therapy involves the separation of allogenic lymphocytes from a donor and injection of lymphocytes in the wife. Prior immunological testing is done, like we saw in the last webinar. There is a prior infection profile, blood group of the wife is important and the donor. The couple is asked to plan pregnancy 4 to 6 weeks after therapy and within 18 months. A booster dose may be given during the first trimester, and LIT can also be given in pregnancy. It is given if the patient presents with pregnancy. Now, LIT is studied with respect to four main areas: the efficacy, the mode of action, patient selection, and side effects. The efficacy of LIT has been proved for a very long time. A few studies which I will tell you is by Daya S. and Gunby in 1994. For certain recurrent miscarriage groups with chromosomally normal embryos, LIT alone has been shown to increase a live birth rate between 75% and nearly 100%. Our own Dr. Manoj Pandey has shown that LIT was associated with successful pregnancy outcome in 82.5% of the cases. And there was a large study by the Recurrent Miscarriage Immunotherapy Trialist Group in 1994, which showed that LIT significantly improved the birth rate, which was statistically significant. Plus, there are various studies by Mowbray, Dr. Howard Karp, Bayros, Liu in 2014, which has amply shown the success of immunotherapy from 72% to as high as 94%. So how does LIT or lymphocyte immunization therapy act? But according to Steinman, the dendritic cells in the skin interact with the antigen and present it to the immune system for response. This leads to further immunological changes, inducing immune tolerance. Also, there is an activation of the Treg cells, where there is a decrease in the Th17 Treg cell ratio and Th1, Th2 cytokine ratio. According to Magni, there is a development of blocking antibodies. LIT appears to enhance the development of blocking antibodies in pregnancy by intentional exposure of the mother's immune system to the living cells expressing paternal antigens. I've just shown this in a small diagram. Is whenever allogenic lymphocytes are separated and injected into the skin, the dendritics, they react with the dendritic cells, which send signals to the lymph system and cause activation of lymphocytes. This causes proliferation of lymphocytes and differentiation to Treg cells and the production of blocking antibodies. So we have already seen the LIT, how the patients are selected in the last webinar on the immunological tests and the fresh infection profile. So if it is so good, are there any side effects? There are minor local allergic reactions. There's occasionally mild malaise. There is no serious allergic reaction or anaphylaxis, and there is no graft versus host disease. According to Kling, who in 2005 conducted a large study of 4,500 cases of LIT, he reported that there was no anaphylaxis, autoimmune disease, or graft versus host disease in all these cases. After LIT, we will go on to immunoglobulins. Immunoglobulins are of two types, intravenous and intramuscular. Intravenous immunoglobulin is a human immunoglobulin preparation for intravenous infusion. IVIG is used in the treatment of recurrent implantation failure, especially when all other known causes of implantation are ruled out, that is, unexplained implantation failure. Intravenous immunoglobulin is a preparation from sterilized, purified human plasma from thousands of healthy donors per batch. IVIG contains more than 95% intact immunoglobulin G with traces of immunoglobulin A and immunoglobulin M. It acts by modulation of complement activation, suppresses the idiopathic antibodies, blocks the macrophage C receptors, and it suppresses the mediators of inflammation, cytokines, and chemokines. Through these mechanisms, it produces the immunomodulatory action. Now, the dosage used for IVIG is very variable in different centers, use different doses. 30 grams of IVIG before embryo transfer, 30 grams of IVIG when fetal heartbeats are seen on USG, 500 milligram per kg prior to embryo transfer. Once UPT is positive, 500 milligram per kg till 28 weeks used by Dr. Caroline Coulomb. According to her, the pregnancy rate is as high as 50%, and according to LTRAM, the implantation rate is 38 to 39%. Now, IVIG has a lot of side effects in the form of it can cause thrombosis, renal dysfunction, acute renal failure, hemolysis, transmission of infection, viruses, and the dreaded CJ disease. It can cause mild headache, fatigue, nausea, vomiting, chills, diarrhea, joint swelling, and it is extremely expensive. It is contraindicated in allergies, renal dysfunction, or wherever there is an IgA deficiency. So what are intramuscular immunoglobulins? Intramuscular immunoglobulin was initially used in the treatment of various infective disorders like poliomyelitis. Intramuscular immunoglobulin has immunomodulatory action that is helpful in cases of unexplained repeated miscarriages and RIF. They have that have inflammatory Th1 response as the underlying cause. Intramuscular immunoglobulins, they form immune complexes that bind to the Fc receptors of the dendritic cells and produce an anti-inflammatory effect. They are also known to bind to membrane receptors on the T cells, inducing suppression by reducing the inflammatory cytokine TNF-alpha. We get in India 16.5% solution for intramuscular injection. The next is steroids. Now, why are steroids used in immunomodulation? Because it has been found, especially prednisolone has been used, it has been found that the presence of endometrial NK cells causes a depletion of the steroids in the decidua, leading to a hostile environment for implantation. And that's why steroids help in replenishing the steroid which is deficient in the environment to help implantation. And immunomodulation with IVIG and prednisolone, according to a study done by Nyborg, Larsen and Christensen, has shown that immunomodulation is a promising treatment for RPL and IF after IVF or ICSI. The next we come to is progesterone, which we all widely used. But why progesterone? Now, progesterone, as we all know, is essential for the maintenance of pregnancy. It is produced by the corpus luteum until week 7 to 9 when the placenta takes over this function. Progesterone stimulates the production of progesterone-induced blocking factor, which I had explained in my first webinar, and induces a T helper response or a Th2 response. So as shown in the diagram, it acts as a link between the endocrine system and the immune system. Progesterone has been shown to have a modest benefit. To just use of only progesterone has been shown to give a modest benefit with odds ratio at 1.38. After progesterone comes the TNF-alpha, anti-TNF-alpha medicines like Humira or Entrel. Now, these medicines are inhibitors of TNF-alpha and work by directly binding to it, thus reducing the level of TNF-alpha. We do not use much of TNF-alpha because it has other side effects and it can cause other infections. However, Winger has found that in a study, he has found that the use of heparin, IVIG, and anti-TNF-alpha has given the maximum success rate. So how do these anti-TNF-alpha agents act? Whenever there is a rise in the TNF-alpha, anti-TNF-alpha basically are antibodies. They bind to the inflammatory cytokine and they do not give the signal to the cell, so it neutralizes the action of the cytokine. Next is intralipid. Intralipid is a 20% IV fat emulsion with 10% soybean oil, 12% egg yolk phospholipid, and 2.25% glycerine water. Intralipid is known to decrease the raised NK cell activity and reduce the Th1-Th2 ratio, preventing implantation failure. According to a study by Dr. N. Duque, has shown that there is a 50% pregnancy was achieved in 50 women who were treated with unexplained repeated implantation failure only with intralipid. So how does intralipid act? Intralipid infusion leads to the alteration in the immunological response at the maternal-fetal interface at the time of implantation and even early pregnancy. The soya oil inhibits the pro-inflammatory mediation, specifically the Th1 cells, and fatty acids activate peroxisome proliferation activated receptors expressed by the NK cells. Now, why is this important? This activation decreases the NK cell's cytotoxic activity, which can enhance implantation and maintain the pregnancy. So how is intralipid given? Various centers have various protocols. Some give on one infusion at the beginning of stimulation on the 4th to the 9th day. Some give one infusion after confirmation of pregnancy. However, it has to be repeated every 15 days for 3 to 6 months. The procedure used to help, the next procedure is, we're talking about now endometrial scratch. Endometrial scratch is a common procedure which is known to help implant more successfully after IVF or XC in patients who have had failed cycles despite the transfer of good quality embryos. So how does endometrial scratch help? Endometrial scratch increases the endometrial WBCs that secrete the growth factor, helping implantation. There is a gene switching in the endometrium. Genes responsible for implantation are not switched on. Endometrial scratch leads to this switching on, favoring changes, helping implantation. Endometrial scratch also helps in the production of cytokines favoring implantation, like leukemia inhibiting factor, IL-11, IL-6, GM-CSF, and IL-15. After endometrial scratch comes GCSF. Now, what is GCSF? GCSF is a cytokine promoting leukocyte growth and trophoblast development. It is helpful in improving the success in IVF with previous implantation failures. It can either be given as the intrauterine route or subcutaneous route. The dose given is 300 microgram per ml intrauterine perfusion or 1 to 1.5 micrograms per kg per day subcutaneously. Now again, here there are various protocols. According to Scarpellini, he uses it on the day of ovum pickup, intrauterine perfusion, and from the day of transfer, he uses it subcutaneously daily. And Werfel uses it every 3 days. The next is low molecular LMWH or low molecular weight heparin and low dose aspirin. Now, whether LMWH and LDH should be used routinely in case of implantation failure or repeated pregnancy loss, even in the absence of autoimmune implantation dysfunction, is still a debate, but it is definitely found to be effective. Now, we are mainly worried about heparin having bleeding tendencies, but let me tell you that heparin is produced by the body in the liver, and it is present in the endometrium at the time of implantation. So what are the actions of heparin? Heparin can block L-selecting on the blastocyst, and heparin can increase the IL-1 and GCSF, which regulates the changes in the surface epithelium, and heparin alters the integrin expression. Now, heparin also increases the SHBG, and for heparin can activate STAT3 for leukemia inhibiting factor and other cytokines. So heparin is extremely important for implantation, and it is extremely low molecular weight heparins are extremely safe to use. So in summary, helping the body to help itself by optimizing the immune system is of central importance. Unfortunately, no immunomodulator is available which fulfills all the standards. It needs extensive research and development of the compounds. However, immunomodulation in pregnancy is going to play an important role in the management of repeated pregnancy loss and repeated implantation failures in the future. So my take-home message is that in repeated pregnancy loss or repeated implantation failure, rule out all known causes. Consider alloimmune recognition at a very early stage. Do all the immunological testing. Think of immunomodulation in the first in the form of active immunization with LIT. Plan the pregnancy within 1 year of LIT and use immunomodulation, that is passive immunomodulation treatment during pregnancy. However, more randomized controlled trials are required. I would like to thank you for a patient hearing. And once again, I would like to thank Bharat Serum and Science Integra for giving us this opportunity.
Thank you, Dr. Mugdha. We will now go to the second part of the webinar, and that is case discussion. And we have invited guests here, senior doctors, Dr. Anita Singh from Patna, Dr. Arun Madhav Barua from Sivsagar, and Dr. Sujoy Dasgupta from Kolkata. Dr. Anita Singh is an ex-professor of Patna Medical College. She is a past president of Patna Obstetric Gynec Society, vice president of FOXY 2020, chairperson Endocrinology Committee FOXY 2014 to 16, member Governing Council ICOG 2015 to 2020, chief consultant JP Hospital Patna, contributed many chapters in many books, many articles published in national journals. So it's a privilege to have you, Dr. Anita Singh, here. Welcome to the webinar. Our second invited guest is Dr. Arun Madhav Borua. He is a consultant gynecologist at Sampriti Hospital. He is a chairperson of Northeast ISAR, honorary president of IMA Sivsagar branch, chairman of FDMSC FOXY 1999 to 2003, organizing secretary of AICOG 2010 Guwahati, published 7 chapters in various textbooks and recent advances, 19 publications in national and international journals, graduate in Assam Medical College, Dibrugarh, postgraduate in AMCH, Dibrugarh, Assam, member of IMA, FOXY, ISAR, IAGE, IMS, ISGE, GAC, I think is a big list, including Rotary International and Red Cross Society of India. Publications, 9 chapters and 16 publications. So it's a privilege to have you here, sir. Welcome to the webinar. And our third guest, is Dr. Sujoy Dasgupta from Kolkata. He is an extremely intelligent and brilliant doctor with an excellent academic career. MBBS gold medalist with honors, MS Obstetric Gynec gold medalist, DNB from New Delhi, MRCOG from London. He has advanced ART training from NUHS Singapore, and he's a consultant in reproductive medicine, Genome Fertility Center, Kolkata, and winner of Professor Geoffrey Chamberlain Award, RCOG World Congress in London in 2019. Welcome, Dr. Sujoy Dasgupta. So we will start with our case studies. We'll start with Dr. Anita with her cases. We will go about like this. We will put the clinical history and the of the case, and then it will be discussed further according to the discussed by the respective doctor, and the case will be open to discussion for all the doctors. So the first case I would like to start with a patient who was 28-year-old and 8 weeks pregnancy with bleeding PV for 2 days, natural conception, obstetric history. She has first
Spontaneous abortion.
Spontaneous abortion 2 years back. The suction evacuation done after USG, and routine investigations were done. Medical management was done. After 6 weeks, tests for RPL were done, including TSH, prolactin, GCT, APLA, profile, and hysteroscopy. I think I will hand over to doctor how she approached this case of repeated pregnancy loss. Over to you, Dr. Anita. Can you just tell how to go about with the management of this patient?
Okay, she came to me in her second pregnancy. First, she had already lost at 8 weeks, for which somewhere else evacuation had been done. When she came to me, she had already 8 weeks pregnancy, 6 weeks pregnancy, and she was having slight spotting. And the ultrasound showed that it was a missed abortion. I managed her medically at that time, and after 6 weeks of that abortion, I did routine investigations which we do for recurrent pregnancy loss, including TSH, anti-TPO antibody, prolactin, glucose challenge test, APLA profile, and I also did hysteroscopy, although the ultrasound findings were normal. But as she was very much worried about her 2 consecutive abortions, I wanted to do everything which has been prescribed for a case of repeated pregnancy loss. And there was no positive finding that I could come across. Everything was normal. Then I just counseled her positively and asked her that nothing to worry about, the next pregnancy will be normal. But at this stage also I did karyotyping of both partners, because the patient was very, very much worried and so keen to have a good pregnancy. That was also normal. And then I simply prescribed her folic acid, methyl folate with zinc and all those combinations, the newer ones. And I also gave her low dose aspirin.
Madam, do you think in such cases immunological problem can be an underlying cause, especially the...
Yes, I thought on that line, but just because we are not very much used to doing the tests for immunology in pregnancy, I must admit that I didn't go for any immunological test in that patient. But keeping that in mind, I prescribed her in the second half of pregnancy, progesterone also, to continue for 15 days, right from 14th day, and get a pregnancy test done every month and try to get pregnant after 3 months of the last spontaneous abortion that she had come, which she had come to me. And with this, I sent her home, and then she came back after, you can say 5 or 6 months after that, with a history of pregnancy test positive. Then I added upon that injection LMWH 40 international units daily, and along with that also I gave her arginine sachets morning evening 1 gram, and I also started with, I continued with aspirin, and I started with LMWH arginine, and along with that I also gave her this this Bhaya serum Bharglow. And I asked her to take it every 21 days and continue. At about 7 weeks of pregnancy, I asked for an ultrasound, and it showed a 7 weeks intrauterine live pregnancy with fetal heartbeat. And I continued with this treatment till 12 weeks of pregnancy, till 20 weeks of pregnancy. And I managed like any other patient with pregnancy. I did her antenatal care and all the tests as prescribed I did. And as she continued her pregnancy, after 20 weeks, I stopped giving her this immunoglobulin, and I continued with the other medication till 36 weeks. Then I stopped aspirin and low molecular weight heparin. and she delivered a healthy baby at term normally.
So, madam, do you consider aspirin, low molecular weight heparin, all these patients of recurrent pregnancy loss, say 2 or more?
After two, I prescribe if I do not find any other cause.
And even immunoglobulins?
At immunoglobulins, recently I have started about 1 year back.
Have you encountered any side effects with this immunoglobulin?
Not till now. Till now I have not.
Okay, okay. Any of the our guest doctors, your opinion, Dr. Borua, in this patient, any additional would be required, or if they, what is your opinion about the medications?
Apparently, the medications in this case would look quite heavy, but you have to all remember that every pregnancy is precious, and we need to take care of the pregnancy by prescribing whatever resources we have in our hand. At the same time, we need to be little honest to our patient to say that they are not evidence-based in totality. So what we do to the patients, basically these patients cannot do all the investigation. Even an APLA panel or even UP cannot be done by many of the patients. So sometimes we have to resource to this sort of treatment without taking any investigations for immunological factors in pregnancy. So I fully agree and support Anita for taking this case, because I'd also take up similar cases in a similar way based on confidence and also total transparency between the consultant and the patient, and with some amount of scientific backup.
But if you feel that if the tests are available to find out the problem, say immune, so would you like to go ahead with the tests?
Definitely, we'd like to offer to almost everyone who has this pain of recurrent implantation failure or recurrent miscarriage. But to be on the other side, many of them just cannot afford. They would be happy to spend that amount in the medicine than to undergo those tests. But the patients are
Right.
also upgrading their education. So many of them today have switched their differences and are agreeing to undergo all sets of investigation at least after 2 or 3 recurrent miscarriages.
Right.
Dr. Mohan, can I ask something?
Yeah, please go ahead.
What are the basic investigations for immunology? I think thinking the region to be something associated with immunology. What are the basic tests that you advocate, and what would be the price of those tests altogether?
I think we had discussed this in our last webinar, but to
But
give
we
a
also
brief,
wanted to know about the price.
yeah, because we do to be specific 4 investigations: lymphocyte cross match, natural killer cells in the peripheral blood, serum TNF alpha, and if possible endometrial NK cells. And the blood investigations, 3 investigations, cost around 10,000 rupees together. And if the endometrial NK cells are required, then maybe 2,000 rupees more. So this is the costing currently which is there in
These three basic ones that you enumerated can be done if the patient is ready to get it done. It is better to
if everything else is normal. I think we'll go to next case. Dr. Suja, you want to share something?
No, I completely agree with Dr. Singh and Dr. Borua. But before going for investigation, I usually tell to my patients that, yeah, we are doing the investigations, but please remember, in around 50 to 60% cases, it may happen that all the investigation reports may come normal, and we may not be in the position to explain you why did you miscarry 2 times. But after the reports come, okay, what Dr. Borua has highlighted, I want to be honest to the patient that, okay, we can do these things. Basically, we are not able to find out any cause, so we cannot provide any definitive treatment, but we can offer you this treatment. It's up to you whether you can afford it or not. But remember, even after this treatment, you still can have miscarriage because the evidences are lacking, but still, at least we don't have any evidence that they are harmful. So we don't know whether these treatments will be beneficial for you or not, but they may not be may not be harmful. So if you wish, you can continue. And I have seen that because majority of the patients, because they have undergone such trauma of 2-3 miscarriages, and when there is no other options, they say that, okay, doctor, when there is no other options, I think I should better go for it. Okay, whatever be the cost, I think I will just continue all these things.
Okay. Thank you, doctor. We'll go to the next
Mohan,
case.
I'd just like to ask you one thing.
Yes.
This can be done in any of the reference laboratories, or we have to ask some special centers to get this test done? Because that is
I think the bigger labs like the SRL or Metropolis, or I think they do it. Though the availability across India might be little difficult, but we have been getting it done across India for patients from different states. So it is possible, and it is possible to get it done and get the reports in time.
okay.
So we will have to explore at local.
Yeah, Dr. Mugdha, would you like to add?
Mainly we do it from SRL. Our patients who come from out of Mumbai, they do the test mainly with SRL or Metropolis, and we get the test from there. So they provide, I think, collection from the clinic also. But in this case, I would totally agree with Dr. Anita Singh and Dr. Barua and this, because very well managed, I'll say.
No, we'll go to the next case. This is a 32-year-old patient, 6 weeks pregnancy, who had come for ANC. First missed abortion at 14 weeks, second IUFD at 26 weeks. IUFD at 26 weeks, had been given aspirin, heparin in the previous pregnancy, but without heparin, but without any benefit. All the investigations for RPL done were found normal. Along with other treatment, I think I'll hand over to Dr. Singh for her expert comments, how she managed this case. All investigations were normal. So
Papers of previous pregnancy, and that showed that she had moderate rise in blood pressure in the pregnancy that she ended in 26 intrauterine fetal death at 26 weeks. I did her investigation for renal disease or any other cause for hypertension, although she was not hypertensive when she came to me. So as she had already been given aspirin and heparin in previous pregnancy, and even then she had intrauterine fetal death, I thought what else to do. So along with all this, again I put this patient on Bharglobe right from the beginning of pregnancy when she came to me at 6 weeks. I put her on Bharglobe also, along with arginine I started, and folic acid and all those were, along with heparin and aspirin, low molecular weight heparin and aspirin. And these things were continued till 20 weeks. Her pregnancy continued normally till 32 weeks. Then she developed late onset preeclampsia. Her blood pressure rose, and in the range of about 160 to 100 millimeters of mercury. I managed it with labetalol, and unlike any other preeclampsia case, but she was not a case of severe preeclampsia, and she had moderate fetal growth restriction, which was detected at around 34 weeks. At 36 weeks, I stopped giving her all these medications. Bharglobe I stopped at 20 weeks, and aspirin and heparin at 36 weeks. And at 37 weeks, I did a cesarean section, and a live male child weighing about 2.9 kg was delivered.
So I think the heparin and aspirin were there in the past pregnancy also, but she had developed, I think, early onset preeclampsia in the first pregnancy leading to IUFD. So all these early preeclampsias definitely have an immunological origin. I think, Dr. Mugdha, would you like to add anything or your comments?
Yeah, I just wanted to ask Dr. Anita, why does she stop Bharglobe in this case and the previous case? She had stopped Bharglobe at 20 weeks. So why was it not continued till term? Any spare reason or?
Actually, this if you look at the formation of placenta and vascularization, the first phase and the second phase is almost over at 20 weeks. Second phase
Correct. Yeah.
presentation. So I thought, as this drug is very costly also and not very much tried actually by me, so I was a bit scared in continuing it for very long time.
Okay.
So because of those two reasons, and I went through few literatures also, and I thought it can be stopped at 20 weeks. And in both cases, I stopped at 20 weeks, and I found there was no difference even after stopping it.
Okay. Okay.
Dr.
Because
Mohan?
as it is known now that preeclampsia has an alloimmune origin as an alloimmune factor as an underlying cause, and it is important because the placental formation which occurs at 20 weeks, there is a second wave of placentation, and if that doesn't happen properly, the patient, this patient who has escaped the immune attack in the first trimester, at 20 weeks the second attack occurs, and if the placentation is not proper, there is improper vascular development in the placenta, and that leads to early onset PIH, which rapidly progresses and leads to severe oligohydramnios and IUFD, and giving immunomodulation in such cases definitely helps. So
I'd like to ask.
There is
Dr. Yes.
Yeah, there is one more thing, that alloimmune factor can, the immunological factor can also cause gestational diabetes along with preeclampsia.
Oh, that's the worst combination. Dr. Sujay, would you like to give your comments on this?
Yeah,
About
I think because it's one of the same type of case. Hello.
yes.
Yeah, similar type of case I encountered. Although she did not have early miscarriage, but she had IUFD and she did all the investigations were normal. So I managed almost in the same line as mentioned by Dr. Anita Singh. Okay, and to be honest, I am also a little bit scared about continuing the Varglo beyond 20 weeks. Okay, because basically one of the reason is the placental the placental development. Another reason is that the person from whom I first learned about the Varglobe, okay, she also told me that she used to stop the Varglobe at 20 weeks. Okay, so I stopped at 20 weeks, but ultimately the result was okay. But sometimes, apart from the immunological factors, unexplained, quote unquote, apparent unexplained immunological factors, we have to keep in mind that the diagnosis of antiphospholipid antibody syndrome is also sometimes difficult because it depends on the laboratories, and sometimes sometimes most of the laboratories from the periphery, what they do, the blood from their area and they say blood to metro cities, so there is delay, and this sometimes can cause problem in detection of the antibodies. And moreover, we commonly test for the commonly occurring antibodies like lupus anticoagulant, anticardiolipin, and anti-beta 2 glycoprotein, etc. But there are some evidences that sometimes, even when these antibodies are not detected, some other rarely occurring antibodies like antiphosphatidyl ethanolamine or serine, they can also be the culprit. So it's not possible for us to test for all the antibodies. And already you have both have mentioned about the problems in testing the immunological factors. So I think there may be some undiagnosed APLA or in presence of the normal APLA results, and of course there may be some immunological factors which is difficult to explore. So I think in this case empirical therapy with aspirin, heparin, and also the Varglobe is justified, I think, in this case.
Yeah, absolutely right, Dr. Sujay, because it has been now proved that the alloimmune and autoimmune problem coexist in many cases, and if they are not properly treated, even if known autoimmune factor and you treat it with the recommended treatment, still the treatment fails because the other factor is not being taken care of. Okay, so thank you, Dr. Anita. We will go to the next few cases.
Mohan. Dr. Mohan.
Yes.
In this particular case, given the choice, would you have given IVIG? Because in our area, only immunomodulation that we can do is by giving parenteral intramuscular immunoglobulin. We do not have access to IVIG. But if you have access to IVIG, do you feel that this patient would be better?
See, the effect what IVIG gives us is we can achieve the similar effect by using a combination of intramuscular immunoglobulin and intralipids. So with a cost effectiveness which is way higher. So I think and the possible side effects of IVIG. So considering all these factors, I think IVIG can be safely replaced by these other simpler modalities of intramuscular and intralipids, which can give the similar effect with the similar mechanism of action while decreasing the Th2 type of Th1 type of response and decreasing the natural killer cell activity. So I think if IVIG is most of the times in our country is being used by certain IVF centers, and yes, the cost is quite high, and the side effects are also high. So I think managing without IVIG also should not be a problem.
My next question is the immunomodulation of progesterone is dose dependent or route dependent, or any type of progesterone can have the same immunomodulation vis-a-vis one another?
Anyone would like to share, Dr. Sujoy or Dr. Mugdha?
Yeah, basically we have been using a lot of dydrogesterone because dydrogesterone is definitely a better immunomodulator according to all the studies, and it helps in reducing the Th1 response. We use it three times a day up to 24 weeks. And although dydrogesterone doesn't help to increase the serum progesterone levels, but yes, as an immunomodulator, it is an excellent drug which can be used. If we have to increase the serum progesterone levels, we do give the oral route is because of a lot of vaginal insertions become difficult for a patient who sometimes lives in a joint family, and they cannot lie down for half an hour. They have certain practical difficulties towards usage. So we use oral progesterones, and if progesterone, we do use intramuscular progesterone.
Okay, but we have seen many of these.
Even I mostly use for this purpose, I mostly use dydrogesterone, but only twice daily till 20 weeks of pregnancy, along with all those dydrogesterone also.
What we all see, all ART specialists, they use a super high doses of progesterone using all the routes of progesterone. Do they have definitely tried to modify the immunomodulation, or do they have something different? That is what also I was interested to know.
Dr.
I think, yes.
I think Dr. Sujoy would be able to answer this question.
Basically, thing is that in progesterone in IVF there are two reasons. One is the main reason is luteal phase support. Okay, but for luteal phase support, the current evidence till now suggests that vaginal progesterone is the best. I'm not talking about the immunomodulation, but for luteal phase support, because if you compare between the oral and intramuscular progesterone vis-a-vis the vaginal progesterone, the uterine concentration of progesterone is almost 14 times higher than the serum concentration. So 14:1, and it's only the vaginal progesterone which have been found to be effective against the preterm labor also, because IVF pregnancies are at higher risk of having preterm labor. But for immunomodulation, sometimes we add dufaston, for those who had previous miscarriage or who had previous implantation failure. But always we add, continue it along with the vaginal progesterone. And usually I personally stop the dydrogesterone by around 20 weeks, but I continue the vaginal progesterone till 28 to 30 weeks because it can have some benefit against the preterm labor.
Thank you, sir.
Okay. I think we'll go to next cases. I think we will go to Dr. Sujoy's cases. Dr. Sujoy, this is your patient, a 36-year-old woman with inability to conceive despite regular trying for 1 year. approached the clinical facility. All the test reports were normal. Patient informed of the history. There was a history of 3 miscarriages. First 2 pregnancies were lost around 6 to 8 weeks, and the third pregnancy around 16 weeks. So you investigated. How do you approach the patient? Over to you, Dr. Sujoy.
Okay, when the patient came to me, she was already investigated for her infertility. That is, basically it was unexplained infertility. And somewhere she was advised some thrombophilia testing. So the thrombophilia testing showed some confusing results. She underwent thrombophilia testing 3 times, advised by 3 different consultants. One showed the deficiency of protein C proteinase. Another showed normal protein C proteinase, but there was like factor 5 resistance. And another result was completely normal. So when she came to me, I just consulted with consultant hematologist. She said that whenever there is doubt, whenever she gets pregnant, at least to prevent the thromboembolism in pregnancy, you start high dose heparin, like you start 60 milligram of low molecular weight heparin and aspirin. Okay. The next slide, please. Sir, the next slide, please. So then we just investigated for the other tests like 3D ultrasound, sperm DNA fragmentation, and apply, etc., karyotype, all were normal. Now the patient's previous 3 pregnancies, she conceived spontaneously. So this time also we encouraged her to conceive spontaneously, but she was concerned that she is already 36 weeks, and her husband now for her job purpose, her husband has to stay outside. Her husband has to stay abroad. So she insisted on going for IVF. We discussed that these are the success rate of IVF, and even after IVF you can have miscarriage, but still she insisted on. So we did IVF and we did the frozen embryo transfer, which resulted in pregnancy after the first transfer. But on the day of the embryo transfer, I started the heparin and the aspirin along with the other luteal phase supports like estrogen, progesterone, etc., as discussed by the hematologist. Okay, now because she had one previous mid-trimestral loss, so I advised the cervical length screening from 16 weeks. It was normal, but around 30 to 33 weeks, I found that the cervix started getting short and the first baby was in breech presentation. So after discussion of pros and cons, she opted for delivery by elective section at 35 weeks. And as she was having high risk of having thromboembolism because of some altered results in thrombophilia testing, so I again restarted the heparin the next day after delivery and continued till 36 weeks. But along with this case, sir, the next slide, please. Next slide, please. Yeah. But along with this progesterone, estrogen, heparin, and aspirin, I gave her the option that you can still consider this as one of the option as Varglob, and she agreed to take the Varglob, and I stopped the Varglob at 20 weeks. But another thing I need to mention, I don't know whether steroid actually had any benefit here or not. She had intractable hyperemesis gravidarum in the early pregnancy, maybe because she is having twin and she needed very high dose of estrogen. Maybe that's why she was having very intractable hyperemesis. It was not controlled with other conventional anti-emetic. So I started prednisolone in first trimester, but within 2 weeks of starting the prednisolone, her hyperemesis was controlled. So so she also received steroid for short duration. So basically she received all types of immunomodulator therapies like aspirin, heparin, progesterone, as Dr. Mukdhara has already nicely mentioned about immunomodulator role of different types of therapies along with Varglob and also short duration of progesterone. So finally she delivered the twin babies at 35 weeks.
Dr. Sujoy, you mentioned about steroids. What is your thoughts? What are your thoughts on use of steroids in RPL, say unexplained RPL in the first trimester, especially in the first trimester of pregnancy?
No, I am little bit skeptical because steroids sometimes can have side effects like risk of preeclampsia, GDM, etc. And there are some also data that in early trimester use of steroid can lead to cleft lip and cleft palate. So usually for otherwise unexplained RPL or RIF, I usually don't advise steroid. But here I use mainly for the purpose of hyperemesis gravidarum. So I'm little bit skeptical about using steroid.
Yeah, there are now studies which have shown that the chances of cleft lip palate are almost the same in patients who have been put on steroids in the first trimester. So yes, in selected cases, especially with high number of miscarriages, prednisolone in the dose of 20 to 30 milligram per day we have used, and it has benefited the patient with healthy baby. So we'll go to any more addition from our guest doctors, Dr. Anita.
I just wanted to know what was the dose of dydrogesterone in this particular case, if it was used at all.
Sir, I used 10 milligram TDS from the day of embryo transfer, and I continued it till the 20 weeks.
Okay. So
And this Barglob you continued till how long? Till how many weeks?
Till 20 weeks. Till 20 weeks. I'm as Dr. Anita Singh also mentioned. So I'm little bit skeptical.
No, I think
don't have
right,
much experience, so I stopped at 20 weeks.
Yeah, Dr. Anita Singh also said that it was costly, but I think now the cost has also drastically come down. So I think we are now free to use it more for a longer duration. Of course, if it is benefiting the patient only, then should be used. So we go to the.
I wanted to one thing. Actually, Dr. Sujay used prednisolone not for immunomodulation, but to control her hyperemesis.
Right.
Yes. So
exactly,
that might not have any effect on the immunomodulation because he used it for a very short period of time.
Right. What is your opinion, madam, about steroids?
Yeah, only 2 weeks. Only 2 weeks.
Steroids, I do not use. I do not use steroids because we were very much. We were told right from the undergraduate time that it causes cleft lip and cleft palate and all that. And as you said, that it may increase chances of GDM, which is already very prevalent in our population. So unless and until there is a very compelling indication to use it, I personally do not use it.
Okay.
So, by increasing the doses of aspirin from 75 to 150?
Yeah, we give
Hello?
Normally, I use
yes,
75 milligram after dinner. But
yes, Dr. Arun, I think nowadays it is recommended to give it in a dose of 150 milligram. But what personally I do, if the patient is weighing more than 75 kg, then I prefer giving higher dose. And if the weight of the patient is on the lesser side, less than 60 kg or something like that, then I still prefer to give 75.
But I think the recent guidelines mention a dose of 150.
Not all guidelines. NICE guideline, I think it is not very clear whether it should be given 150.
Dr. Sujay, you want to add?
Yeah, there are some there are some confusions because NICE still mentions about 75, but they are mentioning that for obese women we should give 150. But on the other hand, like Society of Maternal and Fetal Medicine, they are suggesting 150. So there are some confusions, but personally I have now shifted to 150 in most of the cases.
All the patients.
Over the years, I have cases of gastric erosions with even 75 milligram. So I was a little skeptical to increase it to 150, but we can increase it to 100. Do we have any evidence where we can say that 100 gives a little more benefit than 75?
Any experience, Dr. Sujay?
I think the guidelines are not very clear about those things like immunomodulator actions or the RPL or RIF or APLA context. They have mentioned 150 in the context of prevention of preeclampsia only. That for high risk women, for prevention of preeclampsia, 150 is the recommended dose. But still, because even I've seen that the ESHRE guideline, which are mentioning about the antiphospholipid antibody syndrome management, they are still holding about the 75 milligram dose. So I think there is still some gray area.
Okay. So thank you. I think we'll go to the next case. This was the outcome of Dr. Sujay's first case. This is the second case, 39-year-old with 2 early miscarriages. All investigations were normal. Third pregnancy how do you approach the third pregnancy? I think over to Dr. Sujoy. I think you will be able to take this. Hello.
Okay, the lady, yeah, hello. The lady did not have any problem in conceiving, so she came to me when she came to me after the second loss. I did all the investigations, all were normal. So as I have said, offered her that okay, you can take this progesterone, aspirin, and heparin, but we don't know how far they will be effective. In the third pregnancy, in the first two pregnancy, there was no heartbeat initially, but in third pregnancy, the heartbeat was seen, so we all were happy. But unfortunately, by around at the time when she went for the Down syndrome screening, around 12 weeks, the heartbeat was lost. So again, so she was very much disappointed. So in the next time, fourth pregnancy, the point when she became pregnant, we did not wait till getting the fetal heartbeat. So the point when she got pregnant, I offered starting all these things like heparin, aspirin, and progesterone. Along with that, I started the Varglobe. Okay. So it went well, and the lady delivered by around 37 weeks.
Great. I think this is a good. I think we with paucity of time, I think we'll just go ahead with the next case. This is again with 2 early miscarriages conceived by IUI, severe male factor, all investigations normal. Did 2 cycles of IVF, 3 times embryo transfer or fresh transfer, all beta HCG negative. So, Dr. Sujay.
Okay, next slide, please. Next slide, please. Yeah. So when she came to us, okay, we offered the number of options like hysteroscopy, scratching, implantation genetic testing, like ERA test, blastocyst, and there are some evidences that in severe male factor infertility, testicular sperm aspiration can be a better option. And also we offered the thrombophilia screening and also starting the empirical treatment with aspirin, heparin, Varglobe, etc. So considering all the pros and cons, the financial conditions and the limitation, so they just went for hysteroscopy, blastocyst culture, frozen cycle, and the empirical treatment. So we all did all this. We did the pre-IVF hysteroscopy. We did the blastocyst culture. We did all freezing and did the frozen embryo transfer. And from the day of embryo transfer, I started along with the standard luteal phase support with progesterone, estrogen, etc. I started aspirin, heparin, Varglobe, all. And fortunately, this time everything went smoothly. She got pregnant with single embryo, and she delivered last week. Yeah.
Oh, great. So I think considering all these cases so far, the trio of low-dose aspirin, low molecular weight heparin, and Varglobe is working in all these cases, looks like. So I think we'll go ahead with last 2 cases. I think little interesting cases from our experience. I think Dr. Mugdha will be able to throw light along with all others. So this was a 39-year-old patient, married since 9 years, primary infertility, history of 7 IVF cycles, self as well as OD, all investigations normal, labeled as recurrent implantation failure unexplained, advice surrogacy, but the couple was unwilling. Yes, Dr. Mugdha?
This patient was referred to me from an IVF center because she had 7 IVF cycles and never conceived on her own, and couple was not willing for surrogacy. She had done her own self and even OD cycles. So we did her, all her investigations were normal till date, like all her APLA syndrome, everything was normal. So we did her immunological investigations. Her lymphocyte cross-match was negative. TNF alpha was raised. And after the natural killer cells, also CD3 cells were raised and CD16 plus 56 levels were low. After all the therapy explained to the patient, they were willing to give LIT a try. So we did a lymphocyte immunization therapy with husband's lymphocytes. And after the therapy, the patient underwent an embryo transfer. And intralipid and Varglobe was used on the day of embryo transfer. And she conceived in the first cycle of embryo transfer after LIT. And after beta HCG was positive also, we gave her intralipid for the first, actually we gave it to her for the first 16 weeks because lockdown happened. So she could not travel from Borivali all the way to come here. So we gave her intralipid till 16 weeks and Bharglob every 15 days along with low molecular weight heparin, ecosprin, progesterone as advised by the IVF center and dydrogesterone and other medicines. And currently she has an ongoing twin pregnancy of 27 weeks, both twins doing well, mother doing well.
Dr. Mukta, why did you think of immunological testing? Can you throw more light on the tests?
Because as I had mentioned in my first talk, that there are, in this couple, they had the karyotype done. They had a hysteroscopy done. She already had a laparoscopy and a hysteroscopy done. Husband's count was normal. Even husband's sperm, I think DNA fragmentation was done, which was normal. All her autoimmune tests for thrombophilia and any APLA syndrome, they were all negative. The only thing which was not done, and she was not conceiving, so we explained. That's why I thought of immunological investigations for alloimmunity in the first place.
But you have continued other medications also along with it. After LIT, you have continued other medications also. So do you think it is important to continue or only LIT is enough?
No, because LIT is an active immunization. And there is a certain, because this patient had repeated IVF failures and infertility, her body, there is a immunological memory which needs to be handled with passive immunization through intralipids and Bharglob and dydrogesterone and low molecular weight heparin. So that is why we give it to all patients who had repeated pregnancy loss, because that immunological memory which is already there needs to be handled.
Any of our guests would like to share their experiences of cases, similar cases, multiple recurrent implantation failures?
Dr. Mohan?
Yes.
I'd just like to ask, in all the cases, we are trying to use too many immunomodulation to get an optimum result. So do we have any evidence of using multiple immunomodulations for an optimum result, or we presume?
See, most of the, with our experience, we can definitely say now, comment on this, because we receive patients who have received all the medications, that is low molecular weight heparin, ecosprin, progesterone, all the these medications, and the patients have failed. So these are all passive immunomodulators, but with addition of active immunomodulation and then combining with passive immunomodulation, they have succeeded. So there are no studies where it's like only low molecular weight heparin is used and what are the results, or only ecosprin is used, or only intralipid is used. So therefore, I think a combination is working, and if sufficient numbers are achieved, the studies also will show, will prove it over some time. As we get more numbers, we will be coming out with our data, and I think using multiple medications, if they are not harmful and if they are benefiting the patient, I see no need to worry about it. What is your opinion, Dr. Barua?
Yeah, my opinion is we have only one immunomodulation available for last 20 years, that was injection Bharglob. So I have extensive use of this molecule for last 20 years for varied indications. So what I would like to say, with the same combination that you all have recorded and reported, simply with dydrogesterone and Bharglob, we are getting equally good results. So I think time has come for us to come to a study to compare whether the combination of all immunomodulation is really necessary, or which is the ideal immunomodulation that would give us the optimum result. That is my way.
Definitely, I think that will be an interesting thing, an important thing to, of course, minimize and see which particular medicines are useful in which cases. See, the most important part in reproductive immunology is the gray zone of the investigations and the mode of action of some of the immunomodulators. So as more light is thrown on these aspects, I feel there will be better understanding of the use of these immunomodulators, and then we can choose and pick. We can have subgroups where which method will be useful for which subgroup, and definitely I think that will change the scenario. But yes, immunomodulation is increasingly going to play an important role.
Definitely, because everything to today has been looked after as an immunologically determined factor, because simple tests that we normally everyone does, if we do not have an answer to that, we just label it as immunomodulation. Since we do not have access to all sorts of investigations locally, then we recourse to this sort of molecule like Varglov for last 20 years, and that has been my bread and butter. Didogesterone and Varglov has really saved me and placed me at a different level altogether. So I just
Right. Hello. So I think we go to yes.
in endometriosis cases also to enhance their fertility with a very high success rate.
Right, right. Of course, endometriosis has an increased inflammatory activity. I will go to our next case. It's a 35-year-old patient married since 8 years. History of primary infertility. Very interesting case. All investigations normal. Hysterolaparoscopy normal. Tubes normal, and labeled as unexplained infertility. But with hysterolaparoscopy, we do one more investigation, and I think I will hand over to Dr. Mugdha to elaborate on this patient. We do endometrial biopsy for CD57.
So we do an endometrial biopsy for CD57 cells. It is done from either on after day 18 of the cycle. It can even be done on the first day of the cycle through a biopsy. But since we were doing her hysterolaparoscopy, we did an endometrial CD57 and they were positive. Now, what is the significance of endometrial CD57 cells? Ideally, endometrial CD57 cells are the over-mature cells of CD3 cells, which are the toxic cells. And CD57 are not supposed to be present in the endometrium. They are usually seen in rheumatoid arthritis in the joints. And their presence in the endometrium is definitely an indication of a very bad, either unexplained infertility or a very, very stormy pregnancy outcome. Now, this patient was advised LIT. She decided not to take LIT. But subsequently, the patient had 2 pregnancies which ended in a missed abortion. The patient then agreed to take LIT and she conceived spontaneously after LIT, and she had a completely healthy pregnancy. Immunomodulatory medicines were continued throughout pregnancy, and the patient had a full-term LSCS, healthy, normal baby, nor did the mother have any antenatal complications.
So this was about this is the last case where we discussed about the CD57 part along with other immunomodulators. So I think with this we come to the end of case studies, but there are a lot of questions from the audience, and I think we will go ahead with that. We'll start with the questions without wasting time. The first question is, what is the role of Varglov in RPL and threatened abortion? I think we discussed quite a bit in it. Anyone would like to add to it the role of Varglov in threatened abortion, especially? Anyone has used in threatened abortion? We discussed about as a preventive measure to prevent miscarriage, but patient who has come with bleeding, use of Varglov. Yes, Dr. Borua?
Yeah, I have used this particular molecule not only for threatened abortion, only when there is a documentation of recurrent miscarriage. When there is threatened miscarriage with recurrent miscarriage coming into part, definitely to enhance the immunomodulatory effect, I have used this particular molecule called Varglov. I'll not say I'm getting 100% result, but the results are obtained to the tune of 70 to 80% success rate. That has given me a huge confidence in it.
Okay. Anyone would like to add? I think I'll go to the next question. This is from Dr. Didi Kinney from UK, and she mentions, why do you call it lymphocyte immunization therapy when the inject cells contain cells are leukocytes, and how do you decide which protocol is better in a particular patient, the leukocyte, that is the LIT, or steroids, or intralipid therapy? I think Dr. Mugdha, would you like to answer this?
Yeah, because it is not a leukocyte therapy. The procedure which is involved, we do a separation of the lymphocytes. We have a record of the data, and it will be soon coming out. We are doing a statistical analysis, so we are using the lymphocytes. Now, lymphocytes or mononuclear cells are the ones which are responsible for the antigenicity, and that is why the lymphocyte, it's called lymphocyte immunization therapy. You can even call it mononuclear cell immunization therapy.
And how will you select whether LIT is beneficial or the other passive immunomodulation is beneficial?
See, we generally get patients referred from many centers all over India where they have already used passive immunomodulation and it has not worked. So once the patient becomes like you can say random, becomes a trial herself, and in such a case, then we use LIT and we do the alloimmune testing, because these patients have already been investigated for karyotyping. They've even undergone PGTA. The embryos are very good quality, but there is alloimmune causes have to be selected at a very early stage, which are still not being done in India. So we ideally, before we even start, the patient has already been given steroids, has already been given low molecular weight heparin. And in such cases, when we do the alloimmune testing is done, and then we give lymphocyte immunization therapy, and then the patient is again given passive immunomodulation, and they succeed. In fact, in the next series, we will be talking about a similar case who came from US, and everything else was tried. So I'll keep that case for the next webinar.
Okay, thank you. I think the next question is, does immunomodulation have any role in IUI? Dr. Sujoy, do you think immunomodulation can be used, or Dr. Anita, whether do you use immunomodulation in patients who are undergoing IUI?
In first or second IUI, I will not use immunomodulation in a healthy patient. If she has not been pregnant, she has never been pregnant before. But if after IUI, if everything was normal and the patient fails to conceive, or she ends into early abortion, then of course I will use. But routinely in first IUI or second IUI, I do not use immunomodulation, and even I do not recommend immunomodulation.
Dr. Barua, do you think should be used?
Yeah, in patients where we do IUI for the male factor infertility, and I routinely add them arginine as a part of the therapy before we go for IUI in general. But no other molecule has been used to them, not even Verglobe, but I use only arginine as a part of the protocol for improving IUI results.
Okay, so it definitely it does help in patients if they have an underlying problem. Will one LIT suffice for unexplained RPL if she becomes pregnant, or more sessions are required, and at what interval? Dr. Mugdha?
Yeah, generally the protocol which we use and the dose of lymphocytes we use, we use it only once. We give LIT only once, and the patient then goes back to the center, and then they follow up and delivers. Now, it is very unpredictable because this procedure of LIT is not a lifelong procedure. So it is a temporary procedure which the effect lasts for only 18 to 24 months. Now, for the second pregnancy, once a patient has a successful pregnancy, it is said that there is immunological memory, and the antibodies, the blocking antibodies and the Treg cell separate, proliferation and differentiation will occur. But there is a small group of patients in whom this does not happen, for what reason we do not know. So if the patient again has a repeated pregnancy loss or not conceiving, then we do the alloimmune tests, and then if required we do immunotherapy. Like we've had, I think, just very few cases to remember where we have repeated it after the first pregnancy.
Yeah, actually, there is a paper which has come in 2019 from Brazil, and it has shown that the effect of LIT is the best when it is done before and during pregnancy, or rather than doing just before pregnancy. But what we have found is doing before pregnancy also gives good results. The next question is, how do we give intrauterine HCG before 3 days and blastocyst transfer? Anyone, Dr. Sujoy, do you have experience about intrauterine HCG?
No, I've never used it. Yeah.
I think GCSF you must be using use of GCSF intrauterine.
No, I have not. Basically, I have not used this GCSF or the HCG intrauterine, even in recurrent.
Okay, anyone would like to, sir, Dr. Barua?
No, I also don't use HCG for intrauterine manipulation, or not even GSF.
Okay, the next question is, injection Barglode to be started from which week of pregnancy and how long? Sir, with your experience, I think you...
What we have discussed, as soon as the pregnancy is diagnosed, we start with Barglode and continue it till 20 weeks. And some people use it 2 weeks, some people use it 3 weeks. I personally use it at 3 weeks interval.
I use it as and when the patient is diagnosed with recurrent miscarriage with no other possible cause, just to enhance their immunomodulation, because we never know when she is going to conceive. And I continue this injection with beyond 20 weeks as well, depending upon the growth and development and other satisfactions. And how long? The maximum I have used is 25 doses in one patient, and they were all happy to end up, because if the end result is good, everything seems to be okay.
Have you used this immunoglobulin, intramuscular immunoglobulin, more frequently, like every 7 days or even earlier?
No, I am using it every 20 days. That means every third week. 21 days is the peak time for them. And I always say them, if you forget it on 21 days, you can take it on even 22nd or 23rd day as well. But do not go beyond a month.
Okay. The next question is, should aspirin be started immediately after UPT is positive or after 12 weeks? Dr. Anita? You are mute. She's on.
For immunomodulation, I start as soon as the pregnancy test is, even from before getting pregnant in cases of early missed abortions or bad obstetric history. But just for prevention of preeclampsia, if there is no history like that, then we can start even at 12 weeks of pregnancy. If we see that if the tests say that she has got she is high risk for developing preeclampsia in current pregnancy, then even then we can start in a primary gravida.
I'd like to add, what Madam has said, Anita Madam has said, that for preeclampsia we can delay, because it said that we can start aspirin for prevention of preeclampsia after 12 weeks, but for immunomodulator purpose, for prevention of miscarriage, because maximum time the thrombosis can happen in the decidual vasculature. So in our undergraduate days, we have been told that to start aspirin and heparin after you see the heartbeat in scan, in ultrasound scan, when there is APLA positive case. But even in APLA positive case, nowadays the recommendation has changed. It is said that you should start aspirin before the woman is getting pregnant and start heparin as soon as you get positive pregnancy test. So there has been some changes in our traditional concept. Of course, for preeclampsia purpose, you can wait, but for immunomodulation or for prevention of miscarriage, you should start even before pregnancy.
I fully agree with you, Sujoy. Fully agree with you.
Yes, thank you.
Okay, thank you. We go to next question, whether APTT values should always lie within normal levels, or if it is okay if little higher before starting heparin.
We no longer use heparin in today's content. We have all moved to low molecular weight heparin. So there is no necessity of doing this test at a regular interval the way we used to do earlier. LMW has given us and made us life very comfortable, and we do not subject them to regular tests.
And moreover, the thing is that LMWH usually does not affect the APTT. It's if you have to do a monitor, the therapeutic very high dose of low molecular weight heparin, which we do not use. We use only prophylactic dose, and prophylactic dose of low molecular weight heparin does not basically need any monitoring.
Okay, the next question is a 24-year-old PCOS patient with 2 biochemical pregnancies. What treatment, or RPL investigations are normal? How will you manage, or what is the treatment plan you will recommend in short? 2 biochemical pregnancies, I think, is equivalent. Biochemical pregnancy is now considered as a regular pregnancy loss, and so the prognosis is as equal to documented miscarriages. So I think what should be the line of action?
Actually, patients of PCOS are also PCOS people are more likely to have miscarriages, and this immunological cause for losses are also very commonly found in cases of PCOS. So, in my opinion, PCOS patients also, if they do have this a repeated miscarriage or even one miscarriage, then along with other tests that we do for them and other supportive treatment, we must think about going for immunomodulation, and that will help in these cases also.
Fine. So the next question is, in IVF, we have a suppression of hypothalamo-pituitary axis with supraphysiological estrogen and progesterone. So we cannot rely on body production, and so have to use every means of No, I think the question is not clear. I'm sorry. We'll go to the next question. And in previous 2 pregnancies which resulted in early failure in spite of giving aspirin and low molecular weight heparin, in previous 2 pregnancies which resulted in early failures in spite of giving aspirin and heparin, and in present pregnancy, if we have started Bharglobe, should we still give aspirin and low molecular weight heparin? I think this question is answered. Yes, we do continue. Please give list of investigations done to rule out immunological causes other than APLA, TPO, antibodies, and labs doing those tests. I think that also we have covered. The list of investigations we have said, and the lymphocyte cross-match, NK cells, serum TNF-alpha, endometrial NK cells, and done in SRL or Metropolis lab. How do we administer intralipids? Anyone, Dr.
Mugdha Madam can only answer this question.
No, I do not have any experience of intralipids. Rather, I am scared of intralipids because I have seen and treated cases of intralipid which had been given at some other place, and she had a very bad reaction, and she had come to me. So I am more scared since then. But I know many people use intralipid, but I don't have any experience.
I think Mugdha Madam can answer this.
So we give intralipid. Intralipid infusion has to be given slowly. It's a 20% emulsion which is there as a 250 ml bottle, and we give it IV slowly. If the patient is with us, we give it on the day of embryo. Of course, we don't do IVF, but we recommend the IVF centers to give intralipid on the day of embryo transfer. And as soon as the urine pregnancy test is positive, intralipid is given every 15 days for up to 24 weeks.
Anything about the adverse effect with intralipid? Do you have any experience or heard about it or read about it?
Yeah, intralipid does have adverse effects. So we have to ask a history of whether the patient has allergy to eggs or soya protein. And the first infusion needs to be given very slowly. So we have to look for allergy, keep everything ready for allergic effects. For anaphylaxis also, we keep everything ready, like we have all the injections ready in a tray when we start intralipid. And first infusion is given slowly to look for any reaction. If subsequently if the patient doesn't get any reaction in the first intralipid itself, then subsequently also it will not happen, but then still we do give it slowly. We don't give it at a very fast rate. It's not like in 15-20 minutes you can finish the bottle. It does take 3 to 4 hours.
For 250 ml to be given.
Yeah, 250 ml. We give it at a slow rate every time the
Then the next question is there any role of IVIG in RO and LA antibody positive patients, RO and LA? Any experience, Dr. Sujay, RO antibodies or LA antibodies?
I have just read from the book. I don't have any experience, but they are saying that in anti-RO, anti-live, there is congenital heart block.
Right.
It is suggested by 20 weeks or 22 weeks ultrasound. In that case, I think most of the textbooks, again, I'm saying I don't have any personal experience, but textbooks are suggesting that the dexamethasone is a drug of choice. If not, then you can start in other types of anti-arrhythmogenic drugs. Okay, but I think IVIG. I did not remember whether IVIG has been mentioned anywhere or not.
Anyone would like to add?
And we do test for lupus anticoagulant. Do not test for anti-LA.
Right. So these are antibodies seen in certain collagen disorders, or Sjogren's disease, that is called. And I think I am also not aware about role of IVIG, but as Dr. Sujoy said, steroids definitely play an important role in these patients. I think with this we are coming to almost to the end of our question and answer session. So, anything else anyone would like to share related to what cases we had or the questions, Dr. Barua?
Yeah, what I'd like to ask is, do you have any studies or recommendations to increase the immunomodulation of the male partner? As I routinely sometimes use L-arginine, but do you have studies, because that I have been using it based on my own concept, but do we have anything really in science to enhance the sperm immunomodulation factors, which is also considered very important in implantation?
Not that I am aware of. I think Dr. Sujay or Dr. Anita or Dr. Mugdha, anyone would like to share about?
It's very controversial area, like inflammatory or immunological cases of male infertility, like anti-sperm antibody, because again there is controversy whether we should test, how we should test, and whether we should treat it or not, particularly in the era where we are bypassing the normal cervical and sperm mucus reaction by IUI or by IVF or ICSI. So I think it's underexplored, and the problem in male infertility is that it's often underexplored because we often are not able to treat it. We are not able to treat the causative factor, but we are often going to bypass the pathology. Just we are bypassing the pathology. We are selecting the best quality sperms and we are doing the IUR and IVF. But I think there are some articles which have mentioned that steroids can have some role in management of anti-sperm antibodies. Okay, but since it's still a controversial area largely.
So the sperm DNA fragmentation tests are almost routinely done by almost every reproductive medicine specialist. Do we have anything to alter that particular result? Any treatment where we have?
No, basically thing is that even if we do the test, it usually does not change our management plan. Of course, it is said that if even a couple with recurrent miscarriage, we should do sperm DNA fragmentation test because it can account for the RPL. But in other case, particularly in the era of IVF and ICSI, and or because we have almost shifted to ICSI in place of routine IVF, because if there is sperm DNA fragmentation, although some companies, pharma companies are coming with some molecules, some antioxidants, they are claiming that this can be helpful, but evidence suggests that nothing can be helpful. Sometimes you can consider taking sperm from the testicle while doing ICSI, because these sperms can have less amount of DNA damage. But in the era of ICSI, I think the role of sperm DNA fragmentation in routine as a routine part of investigation where there is no RPL, there is no other factors, is still controversial.
But in RPL, usually we go for DNA fragmentation.
Exactly. It is recommended that
There
yes,
are so many
RPL we should go for it.
empirical treatments which are being suggested to be used for these patients, but I'm not sure how far it is effective. So I think we can do some studies, randomized controlled trials and all that.
I have
Then
actually used
we
those
can be very
molecules.
sure about it.
Oh,
I've used those molecules, but unfortunately, majority of the patients don't have that patience that I will try, wait for 5 to 6 months and see the results. They straightforward go for ART. So patients do not give us the chance to study the results.
I mean, for the non-IVF people who are not doing IVF and the patients are not willing for the IVF at that moment, sometimes
Yeah, then
patients take time
try.
to be prepared for IVF.
Yeah,
In the meantime, we can use those molecules and we can see if it does have any, because there has recently been so many webinars on male infertility, and Dr. Arun, you must have attended a few of them, and most of them are actually emphasizing upon the use of those molecules, and I think we have also used those molecules for quite some time.
right. I think we should consider that factor also. I think a couple of last questions, I think, which have come. One is which immunomodulator to select in which case, and how long to use that. Any answer for this, Dr. Mugdha? Or
For me, I have one answer. I have a immunomodulation in my hand, so I am using Varglove only. I have got one answer because I do not have any alternatives. I have got no experience with any other immunomodulatory drugs at all.
I think you are the king of Northeast, so
Of the Northeast, but since I do not have access to any other molecule and I'm very satisfied with only Varglove, so my experience with this molecule is really highly satisfactory.
What I
Dr.
wanted to ask, even if you are giving Varglove, do you need to give along with that interlipid also?
That is what I say. No, the combination
Dr. Mugdha?
all great, but do you
Yeah.
really? That's it.
No, basically we get references of patients who have taken everything and have failed. So we get
If Varglove fails, then you suggest.
yeah, if Arun fails, then we suggest.
The last question, I think the question is LIT in LIT, are the cells given immediately after preparation or they are stored? I think I will answer this question, because for answer to this question, doctor, you will have to attend our next webinar to know about the controversies, the recent evidence, and the future of immunomodulation and lymphocyte immunization therapy, where all these factors will be considered. So I think we are coming to the end of this question answer session and of this webinar. So I will request Mr. Saket Banerjee from Bharat Serum to take over for his words.
Thank you, Doctor. Thank you for such a nice discussion. I think what endeavor we have started for bridging Bharat, and the reproductive immunology is a subject we are discussing from the very beginning. I think last couple of years, you both, Dr. Mohan Raut and working on it for quite a long time and sharing your experiences all across the country. This webinar, last two webinar, we got a very good success, and this webinar also I share with you. There are 652 registrations. Is there in this particular webinar, and there are doctors who have joined us from South Africa, UK, as well as Muscat. So thank you to all of you. I strongly believe that everybody have enjoyed the discussion, and this is such a discussion which is not only a theoretical references, but also every panelist, every guest, they have discussed of their personal experiences, and which is much more important. With this, once again, I would like to thank Dr. Mohan Raut, Dr. Mugdha Raut, Dr. Suja Dasgupta, Dr. Anita Singh, and Dr. Arun Madhav Barua. Thank you to all of you. We will be expecting you all in our next webinar, that is on the next Wednesday, that is on 19th at 6 p.m. And that webinar, obviously, there will be references, studies, and future of immunotherapy. These things will be presented as well as discussed by our panelists as well as Dr. Mohan Raut and Dr. Mugdha Raut. So thank you, and please join us in the next webinar on next Wednesday, that is 19th of August at 6 p.m.